So we are very fortunate, and without further ado, Dr. Suchowersky, thank you again, and let me hand the floor over to you.
Great. Well, thank you very much for inviting me. And my focus today is going to be to talk about some of the practical management issues related to Parkinson's disease, and to stress that it's not just the treatment of the motor symptoms, but looking at the patient as a whole, and there are many different symptoms that are associated with Parkinson's disease that we need to look at and treat. So hence the name, not just a disorder of dopamine. So I'm sorry, I can't advance my slides.
Oh, no worries, because we have the outstanding and comparable Journey Murray here to help you with that.
You should be able to use, you can use either the arrow keys on your keyboard, or there's also tabs right up under the tab that says your presentation.
Okay, thank you. So we're going to talk a little bit about epidemiology, diagnosis, etiology. Then we're going to talk about treatment of the different stages of the disease and some other interventions that are important. So first of all, Parkinson's disease, as we know, is not uncommon. And it is a disorder of aging, so that about 1 in 1,000 people over the age of 55 will be affected with this condition. The mean age of onset, as you can see there, is in the early 60s, and it's very unusual to have true Parkinson's disease before the age of 30, but we certainly do see a number of patients that are in their 40s and early 50s that are affected. It's a disorder that does not respect any racial or ethnic boundaries, and we know that the prevalence of the condition is reasonably similar in all racial and ethnic groups around the world. Now, the second point I'd like to make is that while a number of people, about 40% of people that are developing symptoms, have yet to be diagnosed because of minor symptoms, that they may complain of a stiff shoulder or they think they're getting arthritis, that about 5 to 10% of people who do have Parkinson's disease are misdiagnosed with another condition, such as even when they have fairly prominent symptoms, people just say, well, it's normal aging, or it is arthritis or something like that, and that's important to realize because, of course, it is a condition that is can be well treated, particularly in the earlier stages. And then, on the other hand, about 20% of people diagnosed with Parkinson's do not have Parkinson's disease, and the most common misdiagnosis is essential tremor. So essential tremor is a very common condition that affects people as they get older. About 1 in 10 people, you may think of Katharine Hepburn, who has the tremor of the head or the hands, and this is not infrequently misdiagnosed as being Parkinson's disease, whereas essential tremor, where the tremor comes out only when the hands are being used, say, to hold something like a cup or a newspaper, is a fairly benign condition, and the treatment, of course, is very different than that of Parkinson's disease. So the diagnosis of Parkinson's has been clarified or sort of made much more straightforward by Hughes and Lees in the UK, who looked at people who had been diagnosed by a neurologist with Parkinson's disease or related condition, and then looked at the pathological examination after death, and developed the UK Parkinson's Disease Society Brain Bank diagnostic criteria. And these are the criteria that are pretty much used worldwide to diagnose Parkinson's disease. And these have positive and negative criteria. So the positive criteria are that you have to have at least 2 of bradykinesia, rigidity, and tremor at rest. The condition always begins unilaterally. and it stays asymmetric for the duration of the condition, so you can always tell which side the condition started on. And the third major point is that when you start someone on levodopa, that they have a good response. The things that you should not have if it's idiopathic Parkinson's disease is significant autonomic dysfunction, gait problems, falls, difficulty with eye movement, particularly eye movement, vertical eye movement slowing, dementia within 2 years of onset. So although some of these things can come on later in the stages of Parkinson's disease, when you see them early in someone with Parkinsonism, then you think of other related conditions, and some of their names are progressive supranuclear palsy or multiple system atrophy. Also, symmetry of symptoms at onset suggests that it's not PD. You have to have absence of other causes such as medications, and of course the most common cause of Parkinsonism probably worldwide is the use of neuroleptic medications. So an individual cannot be on neuroleptics and in fact has to be off neuroleptics for about 6 months because that's how long it can take for the Parkinsonian symptoms to disappear after someone discontinues it before a diagnosis. The other thing to remember is that metoclopramide, which is very widely used for treatment of nausea, can cross the blood-brain barrier and block dopamine receptors and is a significant cause of Parkinsonism in people who use metoclopramide on a chronic basis. And the last diagnostic feature is a normal MRI. So the diagnosis of Parkinson's disease is a clinical diagnosis. And currently, no investigations have been proven to be useful on evidence-based reviews. Rather, it's the negative MRI or CAT scan that helps to confirm that it is Parkinson's disease, for example, rather than something like vascular Parkinsonism. Now, the last point is that when you first see an individual with Parkinsonism, you may not be sure. Sometimes I'm just not sure whether it's true idiopathic Parkinson's disease or whether it may be one of the other or another condition. And so periodic reevaluation is important. And sometimes we watch how the condition evolves over the next 2 years or so based on the symptoms, the rate of progression, to confirm the diagnosis of Parkinson's disease and rule out other conditions. Now, the cause of Parkinson's disease, even though we've known about it for almost 150 years, the etiology is unknown. We know some of the risk factors, and the biggest risk factor is normal aging. There are genetic risk factors, and I'm going to show you a slide in a second outlining some of them. Remote head injury, mild concussion, is associated with an increased risk of Parkinson's disease, as in North America, rural living. So if you live outside of a major city area, the risk is higher than if you live in an urban area. Whereas in other parts of the world, for example, China, it's the opposite, where living in an urban area increases your risk. On the other hand, there are other factors that we know decrease your risk of getting PD, and the biggest one is exercise. And there have been a study done in looking at middle-aged men who exercise regularly, and their risk of getting PD is lower than those men who don't exercise. For reasons that we don't understand, a history of smoking and also caffeine ingestion decreases your risk. Now, I'm not promoting that anyone should go out and smoke, but this has been an association that has been shown in several studies. So right now, this is our thinking of how Parkinson's, or the risk factors for Parkinson's disease, and this is taken from an article last year published by Dr. Schlossmacher, where in younger patients, genetic factors appear to be more important. So if you develop Parkinson's under the age of 50, we think that there is a significant genetic component, and there is a number of genes that now have been identified, such as LRRK2, such as Parkin, which increase the risk of developing Parkinson's disease. As the older you get, the more we think that a variety of environmental factors may play a role. So basically, Parkinson's seems to be due to a genetic predisposition with superimposed environmental factors which were not entirely have not been entirely elucidated. But like I said, the younger you are, the more genetic factors play a role. The older you are, the more environmental factors may play a role. Now, we know that Parkinson's disease doesn't start when you first develop the tremor or the stiffness or slowness, and there are a number of prodromal symptoms that now have been identified that can begin 5 to 10 years before the motor symptoms of Parkinson's. This includes loss of smell, and if you ask people if their smell or taste has changed, a number of them will say that they can't taste food the way they used to. Constipation can predate motor symptoms of PD, as can the development of anxiety and depression. Now, anxiety and depression are common in young people, but if you're in your 40s and 50s and you develop anxiety or depression when you've never had it before, then that may be a prodromal symptom for Parkinson's disease. And the other prodromal system is REM sleep behavior disorder. So now there are ongoing studies looking at individuals who develop REM sleep behavior disorder, anxiety, depression, and following in midlife, and following them prospectively to see how many of these individuals will develop Parkinson's disease. And I believe that the studies are starting to show that these prodromal symptoms will predate the motor symptoms by 5 to 10 years. So this is a study done by Brock, who's a neuropathologist, looking at pathologically at people with Parkinson's disease, or who he felt were in the prodromal stages, showing that the Lewy bodies, or the changes in pathological changes associated with Parkinson's disease, seem to begin either in the dorsal motor nucleus or in the olfactory bulb, which would fit with the loss of smell that can occur early on in PD, and then the pathological changes affect the ceruleus, which may be associated with the other prodromal symptoms, and that by the time the pathological changes affect the substantia nigra, the sort of what we used to think of as the main area where the pathology occurs in Parkinson's disease, that the patient, by his definition, already has moderate Parkinson's disease, or moderate changes in the brain. Other people feel that that there are changes in the gut, and in fact the Lewy bodies and pathological changes of PD have been shown to occur in the gut as well. And so right now we're thinking that if there is an environmental factor, that it may either enter through the nose or through the gut and then spread to cause Parkinson's disease. So our thinking of sort of etiological factors and the way Parkinsonism sort of spreads has certainly changed over the past 10 years since Brock's publications. Now let's turn to treatment, and we'll start with early disease. So now this is where the patient does have some tremor, some stiffness and slowness, and what do we use to treat the patient with Parkinson's? So we don't usually start treatment before there is some disability, that the person is aware of the symptoms. The affected side may play a role, so frequently people don't complain as much if the symptoms start on their non-dominant side. So if the individual is right-handed but they have a bit of stiffness and slowness on the left side, they may not be as aware of it or concerned about it. And the medications we choose depends on age and also whether the person wants to continue working. And we may treat them a little bit more aggressively if there is an issue with employment. So these are the choices of the patients, for the patients. First are the MAOB inhibitors, such as selegiline or rasagiline, which have a mild benefit on Parkinson's disease. There is still some debate on whether use of the MAOB inhibitor should be initiated early because of there were some studies that suggested that it may slow down disease progression, although this is very controversial, and currently they are not indicated for slowing disease progression. Anticholinergics are old drugs which really are not used in North America or Western Europe except in very sort of unusual cases because of their side effect profile, although in some other countries they still are used. Dopamine agonists, pramipexole, ropinirole are the two main ones available in North America. There is a new dopamine agonist called rotigotine, which is becoming available as a patch, and also apomorphine, which is injectable, but that's usually not used in the de novo patient. Amantadine has a mild benefit in de novo patients. Sometimes it's used. And the mainstay of treatment are the levodopa preparations, and you can see there levodopa either available as Sinemet or Prolopa, and both in short-acting and long-acting forms. And then there's another preparation, Stalevo, which is a levodopa-carbidopa with entacapone, which is a COMT inhibitor, which prolongs the duration of action of the levodopa. So in patients that are younger, we might consider dopamine agonists. In patients who are older, I would typically go to the levodopa preparations and stay away from dopamine agonists because of side effects. And in all these medications, or particularly in the dopamine agonists and levodopa preparations, we always want to start with a low dose and increase the dose very slowly on a full stomach. And those drugs can cause nausea, so it is important in early stages to have patients start them on a full stomach very gradually. Just a slide to show you the quite dramatic change that levodopa has resulted in patients with PD. So prior to the introduction of levodopa, that patients had a life expectancy of 10 to 15 years. Since the introduction of levodopa, the patients have near normal life expectancies with good quality of life for up to 10 years after introduction of levodopa. So the levodopa preparations remain the most effective treatment for Parkinson's. They essentially replace the dopamine that that the substantia nigra has difficulty in producing, and there is no evidence that levodopa results in toxicity or increases the rate of progression of of PD. And I just want to stress that because I think there is some older literature that suggests that levodopa should not be used until later on in the course of the disease, and I don't think that there is any evidence to support that at the current time. As the condition so initially when you start someone on medications, the levodopa medications or agonists, that usually they do very well for the first 5 years or so. There's a good benefit. The medication does not have to be taken exactly on time, but over time there is a loss of overall benefit. People on levodopa will notice that if they don't take their the Sinemet or Prolopa exactly on time, that they'll have a wearing off or loss of benefit during the day, and then they'll start to have something known as early morning dystonia or cramping in their feet during the night or early morning, which represents a loss of dopamine within the brain. So now we're getting to treatment of moderate disease. So wearing off is the condition where the dopaminergic medications provide good benefit for 3, 4, 5 hours, but then the benefit is lost before the next dose is taken. So the benefit can be the typical motor symptoms that we all think of, but there are a variety of non-motor symptoms that can occur as well, with gastric bloating or nausea. They may feel urinary frequency or urgency. They may feel dyspnea. There's a variety of sensory complaints, pain, numbness, fatigue, apathy, as well as depression and anxiety can also occur as part of the what we call the off symptoms of PD. And so I've seen patients that every time that their levodopa preparation wears off, that they get very anxious and dyspneic, and their relatives take them to the hospital, and they have multiple investigations, and really all they need is their next levodopa dose to decrease their symptoms. So it's important to realize that it's not just a motor problem. There's a variety of non-motor problems that can occur as the levodopa wears off. The other thing that begins to happen is dyskinesias, which are the writhing movements, choreiform movements that occur when the medication is at its peak. There's also another type of dyskinesia where the patients have dyskinesia first, then they have good benefit from the levodopa, then they have dyskinesia as they're wearing off, and that's a more unusual pattern of dyskinesia that we see. And the off dystonia I've already mentioned. So I'm not going to go into detail of how to manage these patients. I think this is what neurologists typically do, is to juggle these multiple medications to try to give the patient good benefit throughout the day, so the individual ends up taking smaller doses of levodopa more frequently, combined with a dopamine agonist, combined with entacapone, which is the COMT inhibitor, combined perhaps with the MAOB inhibitors to try and provide a constant blood level, which will then allow for a more constant brain level of the dopaminergic drugs. In this situation, we frequently use amantadine because it's shown to work very well for dyskinesia. Now, at this point, other things start to happen, and these are motor symptoms that are no longer responsive to the dopaminergic medications. So while the typical bradykinesia, rigidity, tremor will still be responsive to the drugs like Sinemet, individuals will start to get gait and balance problems and will have not only the stooped posture and shuffling gait, but will have freezing of gait. and this will stop being responsive to the medications we provide. So in this case, physiotherapy is very important. There are safety issues with balance and risk of falls. And then the patients develop more hypophonia, which also does not seem to respond to medications as well. And there are a variety of programs available through speech pathologists to help patients with that. If the medications do not work, then there is one treatment option in the younger patients, and that's surgery, where we put in a deep brain stimulator, or DBS, either into the globus pallidum if the patient has prominent dyskinesia, or into the subthalamic nucleus, which benefits all the motor symptoms and can decrease medications. And this surgery is now regularly done throughout North America and Western Europe, and it is quite effective. What I tell my patients is that it gives you an extra 5 years. So depending if they had good function 5 years before, then it will bring them back to that period. And although the condition continues to progress, that they have an extra 5 good years. This type of surgery should only be done in a specialty clinic, in a multidisciplinary movement disorder clinic, with a team specialized in the management, because there are surgical risks. Of the risk of a stroke or hemorrhage is 1 to 2%. The risk of death is 1 in 200. And there are also a variety of complications, hardware complications that can occur, and programming issues for the deep brain stimulators that need to be carried out. There's also another new therapy that is available for more advanced patients, and that's treatment with a gel form of levodopa, also called duodopa, where the jejunal tube is inserted through a percutaneous gastrostomy tube, and the levodopa preparation is absorbed right through the jejunum. And this therapy has been available in Europe for, I think, a decade or more, but it's just being introduced in North America, and we have several patients with duodopa who are doing very well. And this is for patients who either don't want surgery or have risk factors where surgery would not be contemplated. Now, along with the increase in motor symptoms, we have a variety of non-motor problems which occur in this stage of the disease. There's autonomic nervous system dysfunction, problems with depression and anxiety, which is endogenous, which is part of PD, worsening sleep disturbances, fatigue, apathy, and finally cognitive dysfunction. So I'm going to run through some of those, because these are important, as they can cause a significant decrease in quality of life. And they do require you to ask specifically about them, because the patient or family may not be aware that it is a Parkinson's-associated problem and may not volunteer these symptoms. So first of all, treatment of autonomic symptoms. Patients with PD develop postural hypotension, and so it is important to measure blood pressure in these patients lying and standing at every visit. If their blood pressure starts to drop, which is due to the involvement of the autonomic tracts in the spinal cord, as well as most of the dopaminergic medications we use will also decrease blood pressure. Sometimes the patients just need to have their antihypertensive discontinued if they were hypertensive prior to developing PD. These individuals need to increase their fluid and salt intake. I always tell them to make sure they sit down if they do feel faint, rather than actually faint. And in more pronounced cases, we will use fludrocortisone or midodrine, or sometimes even a combination for treatment. Urinary frequency and urgency is a problem, and in these cases, sometimes amantadine, actually, because it does have some mild anticholinergic effects, can help. Amitriptyline at bedtime helps the nocturia, And then we would work with a urologist after that to use oxybutynin or related compounds. And there is now an intranasal spray of DDAVP, which can also be used at bedtime to decrease the nocturia in particular. But this is a major problem. Drooling is common, and I'd like to point out that it's actually not an autonomic problem. It's because the patients forget to swallow because of the bradykinesia. But if it does become more pronounced and something simple like keeping a candy in their mouth doesn't help, then again, amitriptyline this is a situation where we might use a little bit of an anticholinergic. Also, the ocular solution of atropine eye drops, the 1% atropine eye drops, you can have the person put under their tongue to dry up the saliva. And in more extreme cases, we will use botulinum toxin injections. Seborrhea is common. Sexual dysfunction, again, is not uncommon, and there have been some small studies using sildenafil as well as related compounds to show that they can be used as long as there's no heart problems. These medications will drop blood pressure, and so you have to make sure to tell the individual to be very careful about the postural hypotension that may result. I always say that the bladder speeds up and the bowel slows down. So constipation is a major problem in Parkinson's disease to the point where impaction can occur. And not only does the impaction cause problems in itself, there also is decreased absorption of the medications, and it's very important to tell the patients to keep on top of the constipation with a variety of treatments. There are also some other GI problems that can occur, such as nausea, bloating, cramping that can come and go, which can be quite distressing. So the next thing I'd just like to touch on briefly is depression, which can occur in up to, as you can see there, in up to 60% of patients, with 20% being on having a major depression. But this is not addressed, or was not addressed in many clinics in the past. And individuals with depression do respond to a variety of antidepressants and should be treated, and we do ask about it and administer something like the Beck Depression Scale quite regularly in our clinic now. Anxiety disorders is, again, very common, typically occurs with depression, again, under-recognized and under-treated. And there's just a list of the typical medications that we use in the treatment of both depression and anxiety. Sleep disorders affect pretty much everyone with Parkinson's. They're multifactorial. Besides the REM sleep behavior disorder, patients on these medications can develop restless leg syndrome. Also, the nocturia, if they're getting up 5-6 times during the night to void, then this will disrupt their sleep and can lead to excessive daytime somnolence, which also can be a complication of the medications themselves or the Parkinson's themselves. I don't have a slide on apathy, but fatigue and apathy both occur. And again, this is an endogenous part of PD, which is difficult to treat. You can see sometimes we, or the psychiatrists we work with, may prescribe methylphenidate or modafinil, but this is a hard thing to overcome when you just feel so fatigued or apathetic, and it's similar to what we sort of have been associated with something like multiple sclerosis, but can occur in PD as well. Now, in advanced disease, not only are there worsening problems with the motor symptoms, the autonomic symptoms, freezing of gait, falls, safety becomes a bigger issue, dysarthria, hypophonia, now dysphagia comes into play, again needing assessment by speech pathologists, and now we get into cognitive dysfunction. So the first thing we typically see is formed visual hallucinations. And this is one of the few diseases where there are typically not auditory hallucinations, but formed visual hallucinations where people will see relatives, they'll see animals, either in the yard or in the house, and initially they know they're not real, and the spouse can tell, or the spouse can sort of redirect them so they know they're not real. But eventually they lose this insight. The hallucinations become threatening and more prominent. They typically occur during the evening and during the night. So the first thing to do is to look for treatable causes, such as infection, and a urinary tract infection sometimes is not uncommon in triggering these. And if all treatable causes are ruled out, then we would need to gradually decrease or discontinue the medication. Certainly if the patient is on anticholinergics or amantadine, those would be stopped. Then the dopamine agonists, and then you can see the order there, where the patient is usually left on levodopa by itself. The two medications that we can use if the hallucinations become very threatening, and you can see the levels of evidence that were developed by the American Academy of Neurology reviews, and clozapine and quetiapine are the only two medications that are recommended for use in the Parkinson's patients if you need an antipsychotic. Usually patients respond to low-dose antipsychotics. So there's certainly, for example, with quetiapine, which is easier to use than clozapine because we don't need to do the blood, hematologic monitoring for blood dyscrasias. The quetiapine we can usually use sometimes even half a tablet, 12.5 milligrams a day, to 25 to 50 milligrams a day, and these are nowhere near the doses that the psychiatrists would use for primary psychiatric problems.
And actually, Dr. Suchowersky, sorry to interrupt. Just wanted to ask, when you, because I have a Vietnamese patient with really advanced or reasonably advanced Parkinson's who recently had an inpatient hospitalization because her paranoid delusions were becoming so severe. You know, as you talk about visual hallucinations, she had, kept on seeing people outside her home with guns whom she thought were going to kill her. When you start an antipsychotic with anti-dopaminergic activity, even at a low dose, do you see a significant worsening of motor symptoms?
No, and that's why we would use only quetiapine or clozapine. So the others, like risperidone or olanzapine, will result in worsening of motor symptoms even at low dose. Whereas with quetiapine, you have to go to 300, 400 milligrams a day before you see worsening of Parkinson's symptoms.
Okay, great, thanks.
So after 15 to 20 years of having symptoms, that up to 70% of patients will develop a dementia, and usually the harbinger of the development of cognitive dysfunction is the development of hallucinations. So once people start to have hallucinations, you know that within a couple of years they will start to have cognitive dysfunction progressing to dementia. The older you are, the higher the risk of dementia. And also, we know that once the cognitive symptoms start, that this correlates with the need for nursing home placement. Usually the caregiver cannot manage the patient at home. And people who develop dementia also seem to have a faster rate of progression of their PD symptoms. We now use the Montreal Cognitive Assessment, or MoCA, to assess patients for cognitive dysfunction rather than the MMSE. The MoCA is available free online. You can download it from the website online, and they have several different versions now if you need to use it repeatedly. And it seems to be better to pick up the visual spatial dysfunction that we see in Parkinson's disease, as well as the sort of executive lobe dysfunction. So we almost exclusively use the MoCA now for cognitive assessment at the bedside. Again, once you have a patient with dementia, I take away all the other dopaminergic medications and leave the patient on the lowest dose of the levodopa preparation that will provide them with some benefit with motor symptoms, and I use the short-acting levodopa preparation. So, for example, I would not use Cinemet CR in this situation because there's a more irregular absorption. So low-dose Cinemet or low-dose Prolopa, or just used regularly throughout the day. And at this point, there is a lot of discussion that you need to have with the family, obviously, to explain that if you increase the medications to treat their motor symptoms, you will increase the hallucinations, the confusion, the irritability, etc. So it is a trade-off that the family has to understand. There is a place for cholinesterase inhibitors in this situation, and again, there is level B evidence to show that both the donepezil and rivastigmine does help stabilize the cognitive problems in PD, and I do add them fairly regularly to the patient's medication regime. Now, again, there is some theoretical evidence that the cholinesterase inhibitors may worsen tremor, may worsen the Parkinson symptoms a little bit, but in my experience, this does not seem to be a major problem. Other issues in the advanced patient are driving. And in the early stages, there's no restriction on driving, but as the condition progresses, if the motor fluctuations become unpredictable or frequent, then driving needs to be restricted, and certainly when there are cognitive issues that arise, then driving should be restricted. I try to talk to the families about getting power of attorney and papers for guardianship and trusteeship in place before cognitive issues emerge. And I think this is quite important for this to be addressed. As I mentioned already, once the condition progresses to the time when there's cognitive issues, usually the patient ends up in assisted living. And finally, but very importantly, is providing support to the caregiver. As the condition progresses and the care needs increase, that there is this situation of caregiver burnout, which is very important. Sometimes I try to talk to the caregiver privately, or have the nurse in the clinic talk to the caregiver privately to see what sort of issues there are, what we can do to help, whether it's providing respite beds or home care, etc. Now, there's just a couple of other things I'd like to address quickly in closing. Counseling and education is very important for these individuals and their families. We have very good lay societies and support groups, I believe, throughout North America and Europe that can provide this type of counseling, education, and support. Alternative treatments, the only one that has been shown to be important and where there is evidence for is regular exercise. And so I suggest to my patients that they should all exercise at least 3 hours per week to maintain their flexibility, their gait and balance. And as I mentioned before, there is some evidence in animals that regular exercise may help to slow down progression of the disease. So this is a very important intervention that they need to do for themselves, and it doesn't matter what kind of exercise they do as long as they exercise regularly. We've done a study with exercise and music. Other people have done other studies, and they all seem to be helpful. The evidence-based practice parameter done by the American Academy of Neurology showed that there were no other therapies such as chiropractic manipulation, massage, Traeger, etc., that have been shown to be effective in patients with Parkinson's disease. So this is the only thing that's coming to be effective, shown to be effective. And also the recent studies with coenzyme Q10 and creatine have not been effective in slowing down progression of the disease. So the creatine study was just very recently stopped because of lack of efficacy. So there are no naturopathic supplements or preparations to recommend at this point. One thing that really needs to be addressed is osteoporosis. As these patients are not as mobile, they do have a significantly increased risk of osteopenia and porosis in Parkinson's. They have a high risk of fractures, particularly hip fractures, because of the way they fall. And so monitoring and appropriate treatment is recommended, as outlined there. You can also get hip protectors, which are like hockey pads that you wear on the hips, which if you fall, protect the hip from being broken. Gambling in Parkinson's disease hit the press a little while ago, and this is an issue, and it seems to be linked particularly to dopamine agonists, such as pramipexole or ropinirole, although there have been cases with levodopa, use of levodopa that cause this as well. And in our patients, it seems to be the patients that sorry, I take that back. Even in patients who are treated with low-dose dopamine agonists for restless leg syndrome can develop impulse control disorders. And you can see the risks there, that overall the risk is about 15 to 20%. So you need to ask not only the patient but the caregiver specifically, because if the patient is gambling, he or she may not realize that they're gambling excessively. So you have to ask the caregiver about these issues. But not only is it gambling, but compulsive shopping, binge eating, and hypersexuality that can occur with these drugs, and then this can be treated by modification or change in the medications used. And lastly, I'd just like to mention this is something that we're working on, looking at neuropathy in patients with Parkinson's disease, and it appears that the use of levodopa at high doses over a prolonged length of time can use up some of the B-complex vitamins, leading to an increased risk of peripheral neuropathy, so I'm recommending vitamin B supplementation, particularly B12 supplementation, orally to all my patients to try and decrease the risk of neuropathy. So in conclusion, I hope that I convinced you that Parkinson's disease is a multi-system disorder, not just a motor disorder. It is slowly progressive over several decades. With current treatments, we can treat the patient's symptoms very well and provide them with good quality of life for the first 10 to 15 years. Regular assessment and adjustment of the medications is needed for optimal symptom control. In advanced disease, one needs to look for autonomic dysfunction, cognitive issues, gait and balance issues, all of which have interventions which can be utilized. Caregiver stress is important. And finally, Parkinson's patients need to be managed in an interdisciplinary environment, and you can see all the specialists listed there that we typically bring in to help us manage our Parkinson's patients. Thank you very much.
Wonderful. Thank you so much, Dr. Suchowersky. Really a tremendous overview of a very complicated disease. I think that it's not easy to cover as much ground as you did in about 45 minutes. So thank you again. Right now we're just unmuting the phone lines. Sometimes if they aren't muted, people like weird on hold music comes on and disturbs the presentation. So fortunately we avoided that. I have a couple of questions, but don't want to monopolize it, and wanted just to open things up to all of our attendees around the world. Any questions or thoughts for Dr. Suchowersky?
Hi, this is explain a little bit about the symptoms you see in the REM behavioral sleep disorders?
Yes, so patients will act out their dreams and will move at night in bed when they're dreaming, kicking, and sometimes they do hit their spouse. And sometimes patients have been hit quite badly. So the only treatment that I know of, I'm not a sleep specialist, but is typically the spouse will either sleep in the other room or will separate they'll get two beds so they can separate a little bit. But it occurs not only in the prodromal phase of Parkinson's, but during Parkinson's itself.
And I had a quick question. With the duodopa, instead of surgery with the deep brain stimulator placement, do you still get the same effects? Will you have that reverse of 5 years, or is that still being researched?
Well, it is a levodopa preparation, and what it does is it bypasses the stomach. So in the later stages, when you take pills of levodopa, the absorption is irregular. So it bypasses the stomach and just provides a constant infusion right into the jejunum. So you're maintaining a more constant blood level and brain level. So the patient has a significant decrease in the wearing off as well as the dyskinesia. So they have a fairly good on time throughout most of the day. So it is similar to surgery where the benefit, it does bring them back 5 years as well. It just, in my experience, we have several patients on duodopa now under research protocol, and they're happy with the benefit. I would say it does the same thing, but of course the condition continues to progress.
And what stage would you use that in? Is that more in the earlier stages?
No, in more advanced patients when they're having a lot of fluctuations, motor fluctuations. So the medication will work well for 1 or 2 hours, and then they'll have wearing off, and then they'll work well for 1 or 2 hours, then they'll be off for 2 hours. And when the medication is working, they'll have the dyskinesias. So in those situations, the duodopa, the LSIG, works very well. So it is in sort of moderate to advanced disease. So I think the same patient that you would consider for surgery, you would probably consider for duodopa as well.
Okay, great. Thank you so much.
Is there any association, Dr. Suchowersky, between more benign conditions, in particular things like restless leg syndrome and essential tremor, and increased risk of Parkinson's disease? Certainly patients with PD do develop restless leg syndrome or have restless leg syndrome. I'm not sure, I'm just not aware if that association has been looked at as yet. There are several sleep studies and clinics that are looking at that. So, for example, REM sleep behavior disorder is already a known association. I just don't think RLS and PD association is known yet, whether having RLS predisposes you or increases your risk. With respect to essential tremor, there are some studies that have shown that in families that have essential tremor, there may be an increased risk of developing Parkinson's disease. It's not a strong association, but there may be some increase in risk in some families. Great, thank you. Any other questions from our attendees? All right, well then again, Dr. Suchowersky, can't thank you enough for taking the time. This is really beneficial for all of us, and really are very grateful, and I hope that you can join us again sometime.
Great, thank you very much.
All right, take care everyone, have a great day.